Uh, I have the pleasure to introduce Professor Ahmed Taher, Assistant Professor of Critical Care, Cairo University, will present asymptomatic WPW to ablate or not.
Thank you very much for the introduction. Thank you for inviting me. I've been given the task of talking about the asymptomatic WPW, what to do to ablate or not. So can I have my slides up? Thank you. So yes, so WPW, as we all know, is a developmental annular defect that causes abnormal connection between the atria and the ventricle and manifests itself as in the ECG as short PR, delta wave, and YQRS complex. And we all know that it is a substrate for a multitude of arrhythmias, be it antidromic or orthodromic AVRT, and there's also an increased risk of atrial fibrillation associated with, and it's been in the guidelines since 2019. It's +1 indication that whenever you have a symptomatic WPW, you are justified to go straight for ablation even without trying medical treatment. But the question comes with what to do when the patient has the ECG criteria of accessory pathway, the WPW, but without manifesting any symptoms. And I think we're now becoming to realize that the symptoms are not only palpitations, but they are now appreciated as substrate for dysynchrony and cardiomyopathy, accessory pathway, and this could be also contained within the definition of symptomatic WPW. But what if the patient doesn't have any of these? So on one side, we know we've been doing it for a long time. It's easy, it's successful, it's low risk, so why don't we ablate it in all patients? Obviously, it works for most of them, but there is a risk associated with ablation, and you don't know if your patient is willing, or at least you are justified to offer him this risk in case he doesn't manifest with any problem. And on the other end is why not to wait? Wait until he becomes symptomatic in any form, and at that point, offer him the procedure and do the ablation. The problem with waiting is this. Unfortunately, a portion, not big portion, but a significant, but a portion at least, of patients with WPW may present with pre-excited AF, which could lead to a potential life-threatening arrhythmia. So the question is, should we do something to tell which patient may develop these life-threatening arrhythmias who may benefit for ablation or not? And obviously, you need to calculate this balance. On one side, you need to know what is the risk of ablation, and on the other side, you need to see if the patient has risk features that put him in danger of life-threatening arrhythmia. Now, the risk of ventricular fibrillation is there with WPW, and we know that for many times. This is 1979, and it's been reported that ventricular fibrillation is associated in patients with pre-excitation. Now, interestingly, starting from that point in time, little by little signals started to come up in the literature about this situation in children. In this particular publication, the 15 patients who experienced ventricular fibrillation, they had previous arrhythmias. They were not absolutely asymptomatic. They had some sort of symptoms. But the 3 patients who did not experience any form of arrhythmia prior to ventricular fibrillation, they were all children. Yeah, and keep that in mind. We will come back to it later. Now, reports started to come after that in the following year about the risk of life-threatening or ventricular fibrillation in patients with asymptomatic. This is one of the early publications, 1968, about 128 males. 3 of them died, but none of these deaths were attributed to arrhythmias, and the authors were keen enough to see that one of the patients who died was in a plane crash, and he was in the pilot, so they didn't experience it. So yes, it was at a time very low risk, and reports start to come after that. Same message over and over again. Yes, there is a risk, but the risk is very low. And in this review of like 30 years work of asymptomatic WPW, no sudden cardiac death, and again, 4-year follow-up, 157 cases. No cases of sudden cardiac death. Now, bear in mind that most of these patient population is adults, okay? And actually, when they started to pull up the studies whether in EP studies or epidemiological studies, again, the risk of sudden cardiac death on a variable period of follow-up that spanned up to 6.6, 7.5 is the longest, and up to 18 years or maybe 20 years in epidemiological studies, still very low. But now other signals start to appear in the literature. Again, is there a way to predict those people who get VF in WPW, in asymptomatic WPW? Most of them who experience VF, they have previous atrial fibrillation, but now we are starting to pick up while we're trying to predict which patient that reports that showed VF in this large registry, 15 patients who had VF and asymptomatic, 13 of them were children. So the pattern is recurring. And that warranted to look particularly about the risk in children. So we know that the risk is low in adults, but is it the same in children? And now they started to look in registries and long-term follow-up, and lo and behold, it is higher. In this publication, it's almost 1% in asymptomatic WPW children who experience life-threatening arrhythmia. Again, the intra-cath parameters or markers still the same, so we're still looking at the shortest pre-excited RR, the antegrade refractory period. The numbers and the cutoff points are the same, but the risk is higher in children. And a meta-analysis clearly separated the population into adult and children and identified at least twice the risk in children. The risk of developing ventricular arrhythmia and life-threatening conditions is almost, in this publication, twice the risk in adults, and this was also confirmed in multi-center study that among patients among children with asymptomatic WPW who experience a first arrhythmic event, 65% of these first arrhythmic events are life-threatening. And again, the predictors of these life-threatening conditions in this multi-center study were found to be male 6 Epstein anomalies, multiple and similar intracath markers like the adults. So we know that there is a risk of sudden cardiac death in those patients. We know that children in particular at higher risk than the other, and we may discuss the rationale behind it. But what is the risk of ablation? Again, the ablation of WPW is not new. It's been there for a long time, very low success rate, and one of the most recent registries from Spanish operators, they looked at the risk of major complication in WPW from 2009 to 2017, and it's almost stable. Now, regardless of our experience, regardless of how good we became with ablation of these accessory pathway, the risk is almost still the same. So, what is the conclusion? What do we do? And I don't know if you've seen it, it's not very popular, but actually the European Heart Rhythm Association back in 2019 published 2 documents. One of them for the management of supraventricular tachycardia, but there was another consensus statement that was dedicated particularly to asymptomatic arrhythmia. And in this document, there was a section talking about asymptomatic WPW, and I think the recommendation in this document were a bit more bold than the recommendation in the statement for SVT. And I think they were ahead of their time as well, because it was clearly indicated that being young is a high risk for ventricular arrhythmia, and that was 2019. And they recommended invasive assessment over non-invasive assessment for characterizing or selecting patient with high-risk features. Again, the same thing applies to the cutoffs. And the third recommendation is not to rely on just the recommendation, and if you have intracath criteria of low risk, you need to administer isoprel or at least catecholamine, so that we know that many of accessory pathways are very sensitive to catecholamine. So a more recent expert from the JAC actually highlighted all these findings since the last publications, and suggests an approach of non-invasive assessment of patient with asymptomatic WPW, be it an ECG that shows intermittent pre-excitation or a stress ECG that shows abrupt loss of pre-excitation, but take this with a grain of salt. I will show you why in a minute. And any patient with high-risk features, and in this publication we talked about the male sex, multiple accessory pathway, participation in competitive sports, especially in children, and risk of sudden cardiac death in the family, and familial WPW. All these patients should undergo an invasive EP characterization with administration of isoprel to identify if these accessory pathway at risk or not. And going back, this is 2024, few months ago, publication about the utility and value of non-invasive assessment in patient with WPW. And in this, it was clear, although this was mentioned before in the guideline, it was the non-invasive assessment back in 2019 was class 2B, but it's clear now that even patients with features of low risk in non-invasive assessment by stress ECG, when you bring them to cath lab and study their accessory pathway invasively, some of them still exhibit high-risk features. So despite that non-invasive testing was positive for low risk, the invasive testing said the opposite. And according to the author, the conclusion is that the specificity and sensitivity of non-invasive assessment of asymptomatic WPW is not that high, and you shouldn't rely on it solely. Thank you very much.
Thank you very much, Dr. Ahmed. شكرا جزيلا. Any questions? تفضل دكتور تامر.
This elegant presentation, as usual. I find it very awkward that I was thinking about what Kalapoponi did in back in 2003. I was at that time with my friends in Osama Wazni, and we were talking, how could a patient put 3 diagnostic or 2 diagnostic catheters with a definite CS in place, and you have to, study the accessory pathway closely. So you have to diagnose where it is, not on the surface ECG, of course. So you have to be very crucial very critical in your assessment. And 2,000 patients, almost 2,000 patients, you enroll, and you just stand in front of the accessory pathway and you just don't push the pedal for ablation. This was really astonishing to me, and I don't know how they got the acceptance from the patient's family, even if there are financial issues for getting a $2,000 or $1,000 catheter, but it was very astonishing. So where's that from the ethical point of view?
Well,
ethical.
Now, when we talk about the complication, yes, when we talk about the complication of accessory pathway ablation, we know we do it frequently, we know we do it effectively, and the results are good, but it is not just heart block. I mean, any ablation carries a potential risk. It's a very small risk of other complications, be it precordial effusion, be it pulmonary emboli, be it vascular be it coronary affection from ablation deep on the system. But even if you are in theoretically safe place in terms of being far from the AV node, there is associated risk with the ablation. This is on one side. On the other side, I think and I believe that most of the pathways that we deem at low risk during invasive assessment, we reach this conclusion before giving isoprel. And most of those accessory pathways, if you give catecholamine stimulation, you will reach the cutoffs of high-risk patients. So it is essential, and there are many reports published and presented about cases that on initial evaluation, the shortest pre-excited or at least the accessory pathway effective refractory period were longer than 240 to 250, and after the administration of isoprel, it went down to 220 or even less than that. So you have to be very careful if you bring the patient to cath lab about determining that this actually is absolutely at low risk. And again, there is a shared decision at this point. I mean, there's a prior agreement or a prior discussion with the family that if the accessory pathway is in a relatively far or relatively safe place, okay, then we would go with it. Now, again, this discussion is based on this balance, and this balance is based with the current technology we have right now. And theoretically speaking, if you develop a safer and more efficient technology with very low risk, these complications will be lower, be less, and accordingly our ambition or our desire to ablate these special pathway will grow. So I think this is, yes, there's discussion, accurate assessment, and maybe in the future things will change.
اوكي شكرا دكتور احمد شكرا جزيلا.
Go in, have it, and then you come out and tell him there's 0.05% that he will die suddenly.
تامر الوقت لو سمحت. طيب يعني
It's a balance
Okay.
eventually.